Shaji was supposed to talk about will HDAC inhibition reach its potential in myeloma, and I think that is a question for all of us who've been treating myeloma for so many years now and have been using different classes of HDAC inhibition over the last few years. And just to put things into perspective, as you all are very familiar with this, HDAC inhibition is germane to protein acetylation. There are different targets within cells, 11 dependent histone deacetylases, and once you inhibit these, you get a lot of epigenetic regulation and changes in gene expression. And if you have a non-selective HDAC inhibition, it can actually change the cellular machinery completely and have all kinds of effects on the cellular, gene expression, as well as what happens to different pathways within cells. HDACs have been classified into, there are several different kinds of HDACs, and HDAC inhibitors have been classified into several classes of HDACs. Commonly seen are the HDAC class 1 through 4. Class 2 has 2A as well as 2B. The ones which we are familiar with right now in the clinic, which is vorinostat and panobinostat, belong more to the pan-HDAC inhibitors. And largely, we started studying HDAC inhibition in the context of multiple myeloma because of some of the seminal work which was done in Ken Anderson's lab. And this was data which was presented by Teru Hideshima, where we all know that proteasome inhibition is very active in myeloma because of the protein synthesis machinery. But we also know that there's another pathway of garbage disposal, which is the agrosome pathway. And this, in fact, is regulated by one of the HDACs, which is HDAC6 specifically, and one of the mechanisms of resistance of bortezomib and some of the other proteasome inhibitors would be using this other garbage disposal pathway. And what if you block this HDAC6? Wouldn't you get synergy? So most of the HDAC6 inhibitor studies were based on this concept largely, and this was the result why we went ahead and did the Vantage trial. This is the Vantage 088 study, which all of you are familiar with, which Thanos Dimopoulos presented at ASH now about 3 years back. And what was, this was a humbling experience for all of us in the myeloma world. We did see an improvement in response rates, so certainly we do see an improvement in response once you add an HDAC inhibitor, but this really did not translate into a meaningful progression-free survival benefit. The PFS benefit was about 28 days, and for those of us who treat myeloma, this is certainly not clinically significant. If you hone in and look down as to what was going on here, if you look at the toxicities between bortezomib, vorinostat versus placebo, you saw more thrombocytopenia in people getting the HDAC inhibitor. There was more GI-related toxicity, and there was more fatigue. So one of the beliefs here is, did they get the right dose intensity, because this was a double-blind placebo-controlled trial going forward. Subsequent to this, we have panobinostat from Novartis, which is again a pan-HDAC inhibitor. This is work done by Jesus San Miguel. This was the phase 1B study, which was the classic dose escalation study. They went all the way up to 30 milligrams of panobinostat, and because they did see toxicity, they went down several doses, and ultimately the dose which was picked was panobinostat at 20 milligrams given on days 1, 3, and 5 of a 2-week cycle of the classic bortezomib with 1 week off. This is what the efficacy data looks like. Jesus treated about 62 patients, and if you look at the clinical benefit rate here, it was a little over 60%, and PRs or better was seen in about 35% of these patients. Again, now honing in on toxicity, because that's going to really dictate whether we use these drugs going forward. We did see a lot of thrombocytopenia, even with panobinostat. About 80% of patients had grade 3 and 4 cytopenias. They did have some neutropenia as well, and the rest of it was mainly GI-related toxicity in combination with bortezomib. The median duration of therapy, at least for the ones who were in the dose expansion cohort, was close to 6 months, which is not bad. Again, highlighting the fact that you could stay on the drug for about 6 months or so. Subsequent to this, the Panorama 2 was done by Paul Richardson. This is a phase 2 study. They used the dose, which was the dose expansion dose of panobinostat, which is 20 milligrams given days 1, 3, and 5 of a 2-week cycle. Paul did the study in 2 phases. Phase 1 was 8 cycles, almost like an induction phase, and then went on with a maintenance phase where the bortezomib was dropped to weekly. Panobinostat stayed at the same dosing schedule. 55 patients was treated in this Panorama 2 study. And if you look at the data with the Panorama 2 study, the overall response rate was pretty similar to what was seen in the phase 1 dose expansion study of Jesus San Miguel. It was about 34% with a clinical benefit rate of little over 50% in these patients. This is what the survival outcomes look like. The progression-free survival was close to 5 months. The overall survival, the median, is not yet reached. And if you look at the toxicity, again, there was significant thrombocytopenia. If you look at grade 4, about 50% of patients had grade 4 thrombocytopenia with this. A little over 10% had thrombocytopenia, which was grade 3. Rest of the toxicities, a lot of it was GI, and mainly hematologic toxicity seen with panobinostat. So this combination of panobinostat and bortezomib was effective in relapsed myeloma patients. The phase 3 study is complete, and we are all eagerly waiting to see what the data for the phase 3 study looks like. The trial, certainly based on the abstract or the little information we have, there was a press release on the first day of ASH when we were at ASH suggesting that this trial is a positive trial, and obviously all of us are waiting to see how positive this is. My sense is it's a little over 3 months, close to 4 months of a PFS difference. I think we would really need to look and see as to what the toxicities in this large phase 3 trial are going to be before we can say that we should be using HDAC inhibitor. I do want to spend the last few minutes because we've gone beyond the pan-HDAC inhibitors now, and we all know that these HDACs have isoform selectivity. And when we looked in a biochemical assay, we looked for selectivity of all of these HDACs against the different HDACs which are known in human cells. And if you look at vorinostat and panobinostat, which we've discussed, they do pan-HDAC inhibit, so inhibit 1, 2, and 3. ACY-1215 is a newer, more selective HDAC6 inhibitor. It is approximately 11-fold more selective for HDAC6, and it doesn't have the same kind of, it does have some pan class 1, class 2 activity, but not to the same extent as vorinostat and panobinostat. We've done preclinical data with ACY-1215 in combination with bortezomib, and in our preclinical models had seen nice synergy with this combination. Based on this, we've gone on and done the first-in-man study and done the combination study with ACY-1215 and bortezomib. We were actually able to dose escalate all the way through with single agent as well as with the combination. We are at this where we wanted to go to BID dosing now, and we are currently dosing in the expansion phase of this study. Important to say that we did not reach an MTD with ACY-1215, suggesting that it was extremely well tolerated. And I think this is really critical when we come to think about HDAC6 inhibition. As we go to, as we used ACY-1215 in higher doses, certainly we saw PK levels which kept going up with increasing doses. But when we looked at tubular acetylation, which is the pharmacodynamic marker of HDAC inhibition, we saw that about 160 we see tubular acetylation. Histones would be a marker of non-specific acetylation of the other HDACs. When you go beyond 160, you start seeing that. So this is where you're getting into the pan-HDAC kind of class effect, and where you're going to end up probably with toxicities as well. And that's why we think this is our sweet spot. We think we would like to use 160, which is why we went down to 160 BID. I really want you to focus on this bit here. This was on 22 patients, so a lot less. This is early days with this compound for sure. But if you look at the toxicities here, thrombocytopenia seen in 19% of patients, and the rest of the toxicities were really quite manageable. And consistent with what you would see in this patient population who was being treated with bortezomib. So for the monotherapy outcomes, we had 6 out of 15 patients who had stable disease. In the combination, we had a response rate of 25% with a clinical benefit rate of 60%. And our patients, our longest patient has been on 17 cycles of ACY-1215 with bortezomib, again highlighting the fact that if you're on this, you can stay on this for a very long time without really dose adjusting it. We've done some preclinical work with IMiDs as well. We've combined it with lenalidomide as well as pomalidomide. And when you combine the two, you see nice apoptosis, so nice synergy even with the IMiDs. And we see a downregulation of MYC and IRF4 when you combine ACY-1215 with pomalidomide. So we've actually gone pretty quickly in terms of development. My colleague presented this at ASH last year. This is a combination of ACY-1215 with Lendex. And the nice thing about this study was everybody responded. We had a 100% response rate, and PR or better was seen in nearly 70% of patients. Again, extremely well tolerated. So obviously, as far as HDAC inhibition is concerned in myeloma, we're all waiting for the panobinostat phase 3 study to try and determine how positive is it and what the toxicity profile there is. Early data with ACY-1215 does look promising, and we've actually just based on our very encouraging results with lenalidomide, we've now combined ACY-1215 with pomalidomide and are accruing patients as we speak. Thank you.